Hello, I'm student Dr. Tyler Colstead, and today I'm presenting the case of Trenton. Trenton is a 22-year-old Caucasian male who presented to my clinic complaining of a dull ache in his abdomen. On physical exam, I noted minor distension and a slight protrusion in his abdomen, and a temperature of 100.2 degrees Fahrenheit. His medical history reveals occasional blood in his stool, which the health clinic at his college told him was likely due to his diet high in spicy food. The patient told me that lately he has been feeling uncomfortably full after eating a normal meal. While taking his history, I learned that Trenton recently graduated from college and moved from Oklahoma to Colorado to work with a tech startup, but his parents are very disappointed in him as they want him to enroll in law school and have cut him off financially until he does so. He says that he is losing the weight he put on in college even though his diet and exercise have not changed, and he believes that he is just getting back to normal. He has a fondness for Mexican food and cheap tequila, both of which he consumes probably more than he should. Things to note of importance in his clinical presentation is his chief complaint, which is a dull ache in the abdomen. His symptoms: low-grade fever, unintentional weight loss, and feeling uncomfortably full. Another important thing to note is his history of occasionally blood in stool. And the reason this went untreated was his college health clinic attributed it to spicy food. He's recently moved from Oklahoma to Colorado to work at a tech startup, and also that his parents are disappointed in him and cut him off financially, both of which can cause stress. On physical exam, things to note is his temperature is 100.2 degrees Fahrenheit. He has minor distension and slight protrusion in his abdomen. In terms of things we don't know, which would be nice to know in this case, would be where is the pain? What is the onset? What is the degree of the pain? Etc., etc. His past medical history. Does he have any current or prior diseases that would lead us to lean towards one diagnosis versus another? In terms of blood in his stool, we'd want to know if it's melena or hematochezia and when the onset was. We'd also like to know if he's stressed out. He could be happy that he's freed from his parents, or he could be really stressed out because he's moved to a new state and is also now cut off from his parents. In terms of the fever, we want to know, is there an underlying inflammatory process causing this mild fever? We'd also want to know, how much weight did he lose? Did he lose a little bit, or did he lose a lot? Also, we'd like to know about the alcohol consumption, what he considers to be too much. Perhaps this was the morning after drinking, and he's really hungover and regretting what he did last night, and just said that he drinks maybe more than he should. Or he could think that drinking one drink a week is a lot. We don't know. For the differential diagnosis, with the help of visual diagnosis, which is on the library page, I came up with alcoholic hepatitis, fecal impaction, colon cancer, liver cirrhosis, and amebic colitis, all of which match the symptoms that he's presenting. For careful consideration, I decided to go with the diagnosis of amebic colitis. And on the right, you can see pictures of ulcers in the rectum and ulcers in the sigmoid colon caused by the pathogenesis of amebic colitis. In terms of pathophysiology, amebic colitis is caused by Entamoeba histolytica, and infections of E. histolytica vary in intensity from asymptomatic to severe or fatal invasions. The carriers of this disease are asymptomatic, and the parasite is considered to be in cyst form at this time. Invasive forms of this parasite are called trophozoites. And people with symptomatic amebic colitis cannot spread the disease because trophozoites cannot persist in the environment after they are defecated. Invasive forms of the disease do lead to amebic dysentery, in which the trophozoites invade the intestinal wall, leading to the formation of amebic ulcers. This results in severe diarrhea with blood and mucus present. If the trophozoites penetrate the intestinal wall, the infection can spread through the bloodstream, most likely resulting in a liver abscess. How is amebic colitis linked to Trenton's current symptoms? Trenton is presenting with bloody stools, which can be caused by the ulcers from the invasive E. histolytica. Abdominal pain can be caused by irritation of the gut and also by liver abscesses. Weight loss in this disease is common. Fever occurs in approximately 7 to 38% of those with amebic colitis. And as I said before, the liver abscess can explain the abdominal pain and can also cause general discomfort or ill feeling, which could attribute to the feeling of fullness. Also, it's known that in amebic colitis, those with a history of alcohol abuse are more likely to have it. In terms of treatment, we would want to use a systematic amebicide followed by a luminal amebicides. We'd use a systemic one because E. histolytica pathogenically can travel all over the system. So we want something that can treat everywhere that it can possibly infect. And for this, we use metronidazole, 750 milligrams orally or by IV 3 times a day for 7 to 10 days. And then for the luminal amebicide, which helps prevent the spread of it, we would use paromomycin, 25 to 35 milligrams a day for 10 days. After treatment, for the prognosis, in terms of the intestinal infection, we would expect the diarrhea to last no more than 5 weeks. For the liver abscess, after treatment, 80% have symptoms lasting a few days to 6 weeks. Depending on the damage, the liver could have residual lesions which show up on ultrasound. If this liver abscess is untreated, it is progressive and often fatal. After we treated the patient, we'd also want to talk about we'd also want to educate the patient in the disease. I find the main factors to be in prevention and screening. We'd want to talk about sanitation, drinking bottled water or use of iodine when using unbottled water, and avoiding consumption of unpeeled vegetables and fruits, which could have E. holistica and its cyst form on them. And we would mostly have to worry about this in endemic areas, such as third world countries that are not as sanitary as America is. For screening, if he did test positive for amebic colitis or for E. histolytica and had amebic colitis, we'd want to screen those who have come in contact with the patient that are at risk. In terms of ethics, I would want to conduct myself in a manner that the patient feels comfortable to discuss potentially embarrassing subjects. I'd also want to be sensitive to the fact that the person might be homosexual. And when I ask about his sexual orientation, I will want to talk in a manner that is neither offensive nor derogatory. And most of the time, we need to remember that the physician is the one that feels more uncomfortable than the patient does when talking about their sexual orientation. But in the case of amoebic colitis, it is important to talk about the sexual orientation because it's part of the pathogenesis of the disease. Any questions? Thank you.